Hola, muy buenos días. Mi nombre es Daniel Núñez y a nombre de la Universidad del Desarrollo y de la Universidad de Talca quiero darles la bienvenida al encuentro internacional denominado El rol de la regulación emocional en la salud mental, perspectivas básicas y aplicadas. Les invitamos a participar en esta actividad realizando sus preguntas a lo largo de ella en la sección preguntas que está en la barra inferior de Zoom. Les pedimos que el chat lo usen solo en el caso de problemas técnicos y otras interacciones con el panelista. Esta actividad está siendo transmitida a través del canal de streaming de la universidad, uddtv.udd.cl, y durante los próximos días estarán disponibles los videos de las actividades autorizadas por los expositores en el sitio web de cada facultad. Para seleccionar la interpretación simultánea, deben seleccionar el icono del globo terráqueo que encontrarán en la barra inferior de su panel de Zoom. Al pinchar, deben seleccionar el idioma en el que quieren escuchar la actividad, sin importar en qué idioma hable el expositor. De todas formas, estaremos pendientes al chat por cualquier problema o ayuda que necesiten. To select simultaneous interpretation, you must select the globe icon that you will find in the bottom bar of your Zoom panel. You must select the language in which they want to hear the entire activity, regardless of which language the exhibitor speaks. We'll be waiting to chat for any problem or help you need. Bueno, esperamos que la tecnología, ¿cierto?, y las conexiones nos acompañen y les pedimos a la vez que su consideración ante la eventualidad de algún fallo. ¿Okay? Agradecemos a todos los profesionales y estudiantes interesados en participar en esta actividad. Bien, la conferencia que a continuación vamos a presenciar se titula The Paradox of Emotion Regulation in Psychosis and Where to Go From Here, y estará a cargo de la doctora Tania Lincoln. Ella es profesora del Instituto de Psicología de la Facultad de Psicología y Ciencias del Movimiento de la Universidad de Hamburgo, en Alemania. Uno de sus principales focos de investigación es comprender cómo y por qué surgen y se mantienen los síntomas psicóticos. En sus trabajos recientes ha puesto un gran énfasis en el estudio de la interacción dinámica entre la vulnerabilidad de las personas por una parte y el procesamiento de la información emocional y cognitiva por otra. Actualmente investiga la eficacia de distintas intervenciones adaptadas para las alucinaciones, delirios, síntomas negativos y la relación entre psicosis y trauma. Además, está involucrada en la mejora de los tratamientos psicosociales para la psicosis mediante el desarrollo de guías clínicas, ¿cierto? Y colabora en un proyecto conjunto para reducir la coerción en psiquiatría y para explorar posibilidades de atención sanitaria digital para psicosis. Ella ha liderado distintos estudios, ¿cierto? Y como producto de los mismos ha publicado más de 200 artículos científicos, ¿cierto? En revistas de alto impacto. Es miembro de algunas asociaciones científicas, entre ellas la Academy of Science Hamburg, the European Scientific Association on Schizophrenia and Other Psychosis, y forma parte de la European Negative Symptoms Research Network, entre otras. Bueno, es para nosotros un honor tener la posibilidad de escuchar a la doctora Lincoln y agradecemos a ella el haber aceptado nuestra invitación. Dr. Lincoln, please, go ahead.
Okay, thank you very much for inviting me to this symposium. I'm really excited about the invitation, and it's an honor to be talking about my work here with you today, and I'm especially looking forward to the discussion. So I hope you can now see my screen, otherwise please let me know. I'm going to talk about the paradox of emotion regulation in psychosis and where to go from here. And as has been said in the introduction, emotion regulation has been a focus in my research over the last 10 years. And recently, however, we've come up with a few paradoxical findings. And these findings, I will bring them up in the talk, and so maybe you can watch out for them and see how many paradoxical findings you come up with as a sort of attention check. And maybe as a sort of spoiler at the beginning, to be honest, I'm not really quite sure where we will be going from here. So I was hoping that we could discuss some of the open questions at the end together. But before coming to the topic of emotion regulation, I'd like to start out a little bit on a broader note with two common misconceptions about psychosis that date back a long time back to the time of Karl Jaspers and even beyond. Karl Jaspers, a famous German psychiatrist and philosopher, is often quoted for his statement saying that delusions and hallucinations are alien experiences and that they are impossible to understand. And in fact, many people still think about delusions and hallucinations in this way today. And this way of looking at delusions and hallucinations is continuing actually to influence the field until today. And that is relevant because if we believe that delusions and hallucinations are alien experiences and not possible to understand, this implies that we can't really apply normal theories and models of information processing from psychology to the experience of delusions and hallucinations. Fortunately, however, the field has moved on, especially the first assumption, the assumption that, that these experiences are alien, has clearly been rejected now based on abundant epidemiological research showing that actually delusions and hallucinations can be quite common experiences, that even people who are not classified as psychotic experience paranoid beliefs or experience hearing voices or experience phenomena that are close to hallucinations. So we now actually see delusions and hallucinations as being on a continuum from people who never have these experiences over people that have them occasionally, maybe very mild experiences, to full-blown psychosis at the end of the continuum. And this continuum view of psychosis has spurred a lot of research that uses the continuum to look at the association between risk factors and vulnerability indicators and psychotic symptoms across the whole continuum. So we don't always have to just compare patients who have been diagnosed with a psychotic disorder to healthy controls, which is sometimes also a bit of an artificial comparison, but we can also sample now from the continuum and look at subclinical populations and risk factors that are associated with psychotic experiences in these populations. And I'm saying that at the beginning because some of the work that we have done has used this method. Anyway, this continuum view then thus provides a really, really good basis for trying to understand delusions and hallucinations. And we've come quite a way, even now in our understanding of psychosis. And one thing is that we over the last decades, different researchers have identified social risk factors for psychosis, such as trauma and bullying experiences, discrimination, social exclusion, migration. And this research has been replicated quite well, and I think it's not really being disputed anymore, that these factors go along with an increased risk of psychotic symptoms later in life. And we also know that social risk factors, so trauma and bullying experiences in the past, are predictive of social stresses that people are experiencing nowadays in their everyday life. So someone who's been exposed to childhood adversity is also more likely to be confronted with psychosocial stresses now as an adult. And there's also a lot of research showing that social stresses on a sort of everyday basis, even minor social stresses, that they are triggers of psychotic symptoms such as delusional beliefs or hallucinations. And so this gives us a really good frame, actually, now for then studying the mediating and moderating psychological mechanisms that explain these associations. And one mediating mechanism that's been looked at that mediates the association between current social stress and psychotic symptoms is emotion, or our emotional responses, or to be more specific, negatively valenced emotions such as anxiety, shame, anger, sadness. And this is what's often termed the affective pathway to psychosis in everyday life. And it's well backed up both by experimental research and by research using the experience sampling method. Experimental research is what we've been doing in our lab quite a lot. And one of, or basically the earliest study, the kickoff study for my experimental psychosis research was this study using healthy participants and randomizing them to a stress and a no stress condition, which was followed by stress and a no stress condition the other way around. And so every participant was exposed to both conditions, and stress was building site noise, and the no stress condition was no noise. So a really, really simple experiment. And our hypothesis was that in the stress condition, the participants would be reporting more paranoid beliefs than in the no stress condition. And that this association or this increase in paranoid beliefs would be mediated by their emotional responses to the stressor. And that's exactly what we found. We found that both negative emotions, I use negative emotions for short. What I mean is negatively valenced emotions. That negative emotions increased and that they mediated the effect of the stress induction on paranoid beliefs. And actually anxiety was the strongest mediating factor compared to the other emotions. And we've been using different types of stressors now and larger samples and clinical samples and comparing different clinical samples and high-risk samples. And we've come up with the same pattern of findings in several of our experimental studies. Another line of research that was started off by Ines Muin-Germaes and colleagues and Jim van Os from the Netherlands used the experience sampling method, which you're probably familiar with, but just in case people aren't, that's a method, used to be with pen and paper diaries, now it's applied with smartphones, where people are handed a smartphone and are assessed on this smartphone several times a day. So a typical design would be, say, 10 measurement times a day over the course of 6 or 7 days. And the phone beeps, and at each beep, the participants are required to answer a set of items, to report on their feelings, and in this case, to report on their paranoid beliefs, independent of whether they're just going shopping or sitting on the tram or have just gone to bed, although actually they don't get called up, beeped at in the night, but still in the evening and in the morning. And that gives researchers the possibility to then look at the cross-lagged associations between negative emotion at one time and paranoid beliefs or hallucinations or whatever is being assessed at the second time point. So to look at the temporal precedence of negative emotion and symptoms. And there's been loads of studies using this method, and all of them back up the effective pathway to delusions and hallucinations. And sometimes it's been criticized that it's maybe not so good to just rely on self-report in the assessment of emotions, because if you were really sort of finicky about it, you could say that if someone's already experienced having a paranoid thought, then they're also worried that they also might be worried about it. So anxiety and self-report and paranoid beliefs are not really so easy to disentangle. And for this reason, we thought it would be interesting to also use a psychophysiological assessment of arousal. So we used an experience sampling method, but we equipped our participants with devices that continuously measured their heart rate variability, and their skin conductance levels as measures of physiological arousal, and also heart rate variability of measure of adaptability. And because that was a little bit more taxing for the participants, we did a shorter study frame of 24 hours and used a higher frequency, because we were really interested in sussing out whether an increase in arousal or a decrease in adaptability and heart rate variability would be would precede psychotic episodes or paranoid episodes. So we defined paranoid episodes as being above a certain cutoff on the paranoia scale that we used. So you can see the paranoid episodes here. And then we could classify these episodes into not being present, the pre-onset phase, the event phase, the pre-offset phase, and the post-offset phase. And what you can see here is that the skin conductance level starts to increase before the paranoid episode begins. And this pattern is even more pronounced actually for heart rate variability, that shows a clear decrease before the onset of a paranoid episode. So that, I think, is an even stronger indicator of the assumption that arousal, the physiological indicator, actually comes before the symptom is experienced and reported. So to sum up, the basis for even looking at emotion regulation is that there is an effective pathway to psychotic symptoms. And this leads us then to the question of why there is so much negative affect, or why it is translating into psychotic symptoms. And one hypothesis that we had a while already, that we've been thinking about for quite a while now, is whether this might be explicable by difficulties in emotion regulation, which is what this talk is about. And I will skip defining emotion regulation, because I know that you already heard the talk by James Gross, and basically we used the same definition, although with an emphasis on what he calls the response-focused emotion regulation, but also reappraisal, so looking at what people do when they have feelings that they want to change. And we've broadened our perspective a little bit to also include automatic regulation, because that's an area that clicks in well with basic research in psychosis, showing that there are problems in physical stress regulation. And from what we know about social risk factors and genetic risk factors in psychosis, we have good reason to believe that these could give rise to problems in emotion regulation that could then be explaining the effective pathway to psychotic symptoms. One is, if we look at the social risk factors, and I think you've been talking about this at your meeting, or still will be, there are developmental theories that point to various mechanisms that underlie the development of emotion regulation, and these mechanisms include observational learning and attachment relationships. And that has been backed up by empirical evidence, the fact that people that have been experiencing adverse events then later have more difficulties in emotion regulation. And genetic factors in psychosis are seen as one of the reasons for neurocognitive problems later on, so for a neurodevelopmental cognitive impairment that's associated with schizophrenia. And not to delve in deeply, but prefrontal cognitive capacity that's been linked then also to the capacity to downregulate emotions using reappraisal. So there's also an intuitive link on this side. And both genetic risk factors and social risk factors can give rise to neurodevelopmental, to give rise to dysregulation of the autonomic and the neuroendocrine stress regulation systems, so to the psychophysiological side of emotion regulation. So that's the empirical, and that's the theoretical basis for expecting difficulties in emotion regulation. And I'm now going to go on to talk about the research that's been conducted in this area, both by our group and partly also by other groups. And this is probably something you would be familiar with. There are different methods that have been used to study emotion regulation and still are being used. And I've decided to sort the research that I will be presenting now by these methods, and give you some examples for studies using each of these methods, and also then talk about their links to the affective pathway of psychosis. And the method that's been used the most frequently is using so-called cross-sectional questionnaire measures of emotion regulation, in which patients or participants are asked to rate how often they use specific strategies or how successful they are in using these strategies. And in the area of psychosis, there are so many studies that have been using these questionnaires that it was worthwhile already conducting a meta-analysis. And that's what a postdoc from my lab, Lea Ludwig, did as part of her dissertation. And she analyzed the difference in the self-reports on emotion regulation between patients with psychosis and healthy controls. And she also looked at studies that had reported on correlation between emotion regulation difficulties and positive symptoms of psychosis. And what she found was that there were a set of strategies such as suppression, rumination, and self-blaming that were used more frequently by people with a psychotic disorder. And there were a set of strategies such as distraction, reappraisal, acceptance that were used, well, actually acceptance, not distraction and reappraisal, that were used more frequently by the healthy control participants. So I think you've probably heard the distinction that these strategies at the top here, that they're often seen as maladaptive, because overall they're associated with lower well-being, more psychopathology, which doesn't necessarily mean that they're never effective, which is why some people have criticized this distinction. But nevertheless, we often use it or call it putatively maladaptive strategies, whereas the putatively adaptive strategies are more often used by the controls. For acceptance, there hadn't been many studies, and those did not show a significant effect. And then we also included overall scores and emotional intelligence scales, so a sort of a bit of a broader category that we then labeled managing emotions, with a higher score indicating higher self-perceived success, and that was also then higher in the healthy control group. So to come to the correlation studies, they were not so many that looked at correlations, but those that did found that the so-called adaptive strategies showed no significant association with psychosis, but a tendency to be used less, and the maladaptive strategies showed a clear significant correlation in terms of a positive association with symptoms. So these questionnaire studies basically show that, yes, from the self-report side, there are problems in emotion regulation. And in terms of whether these problems explain the affective pathway to psychosis, this was skipped. Yeah, now. So now, we've conducted some studies looking at whether these self-reported emotion regulation difficulties moderate the link between current social stresses and psychotic symptoms, and have found that they do. And I'd like to give you one example of a study. In this study, we assessed participants with a clinical high risk of psychosis. So these are participants that have been shown to really have an increased risk, so to have a high risk of developing psychosis during the next 2 to 4 years. And we compared them with a healthy control. We assessed them for emotion regulation at baseline and compared them to a healthy control group. And then we exposed both of these groups to a social stressor. And this social stressor was a game called Cyberball, where people were asked to play a ball game with virtual other players and to throw the ball to the other players. And in the social exclusion condition, they then get excluded by the other players, so they don't receive the ball anymore. This is a paradigm that's used a lot in social psychology, maybe you know it, and reliably induces negative feelings. And this is what happened in all of the participants. So their negative emotion went up, but in the clinical high-risk group, we also found the increase in paranoid beliefs, and that was mediated by the negative emotion as expected. And we also found that the emotion regulation. Sorry? Okay. We also found that the difficulties in emotion regulation reported at baseline, that they moderated this pathway. So just as a backup for this model. The second set of studies has looked at heart rate variability as a psychophysiological indicator of emotion regulation. But I noted that because that's also been a focus in psychosis research. And here too, there are so many studies that it was worthwhile conducting a meta-analysis. And this meta-analysis clearly showed a significant group difference between patients diagnosed with a psychotic disorder and healthy controls in two indicators, or in the two main indicators of heart rate variability, namely the high frequency domain of heart rate variability and the RMSSD, the root mean square successive difference. And this clearly shows that there is a problem here in schizophrenia. This problem has been found for some other mental disorders as well, but it's much more pronounced in patients with schizophrenia. How is this linked to emotion regulation? We also looked at that in one of our studies. And here we used data in which we had self-reports of emotion regulation, we had data on heart rate variability, and we had data on self-reported stress levels during a stress induction experiment, and on cortisol levels as a physiological indicator of stress. And what we found was a quite strong link between heart rate variability and self-reported emotion regulation in can you see if I use the pointer?
Yes.
That's good. That's good. Now I've got it on the right side. So what we found is quite a clear association between heart rate variability and emotion regulation. And emotion regulation was then linked to the stress responses, both for the self-reported and stress and for the cortisol levels. So we could say that self-reported, self-perceived emotion regulation is somewhat of a mediator here, really, between the physiological adaptability and the stress response. I now come to the experimental studies on emotion regulation. And I've heard that this is one of the things that you're actually interested in your project as well. And this is an area where we've come up with some of the interesting findings. A typical experimental paradigm that we have used, and it's been used in some of the other studies as well, typically induces emotions using the International Affective Picture System, using emotion eliciting stimuli such as dangerous animals, for example. And then in the next step, participants are asked to rate their emotion and then to apply a strategy, which often is already instructed at the beginning of the experiment. And then they are shown the emotion eliciting picture again, and then they're asked to re-rate their emotion. So what the outcome measures that we were interested in and that have been looked at are the difference in subjective rating from before the application of the emotion regulation strategy to after the application of the emotion regulation strategy. And of course, this paradigm can also be combined with a psychophysiological assessment of emotional responses, or with an assessment of neural responses, so with the fMRI assessment or EEG. In the study, I'm going to show you two studies. I will show you two studies from our lab where we combine this type of paradigm with psychophysiological assessment of heart rate and skin conductance levels. And in the first study, we included patients with psychotic disorders, patients with anxiety disorders, and healthy controls. And our hypothesis was that the patients with psychotic disorders would be less successful in reducing anxiety and sadness using reappraisal, and that what they report in the questionnaires, so their so-called habitual use of reappraisal, would be predictive of how successful they use reappraisal in the lab, in the experimental paradigm. And thirdly, we were also interested in looking at whether certain vulnerability indicators in psychosis, such as neurocognitive impairment, are helpful in explaining the group differences in emotion regulation. So here we use the trail-making test as an indicator of neurocognitive impairment. And what we found is that you can see here in the left graph that these are the ratings of subjective emotion intensity at baseline, and these are the ratings after emotion induction, so after looking at the picture, and these are the ratings after using reappraisal. And on the right-hand side, you can see the same for the view condition. So you can see here that reappraisal is successful in bringing down negative emotion compared to the just view condition. So there was a main effect for reappraisal. So everything is fine, just there was no group difference. All groups were equally successful in bringing down their negative emotion using reappraisal. And so we had no condition time group effect. And we found the same pattern of findings if we look at the skin conductance rates or the heart rate. Skin conductance was a bit of a different type of analysis. That's why you can only see a post-emotion and a post-reappraisal graph. Whereas here for the heart rate, we've got baseline, post-emotion, and post-reappraisal. And you can see there's not much happening there at all, and there's definitely no group condition interaction. There is a group effect with patients with psychosis showing higher heart rate levels overall, but that was to be expected. That's what we always find. And then, interestingly, we found no correlation between self-reported reappraisal in the questionnaire assessment at baseline and the success in using reappraisal in the lab. So that was study 1. In study 2, we used a very similar design, just that in this case, we didn't have the anxiety control group, and we focused on patients with acute delusions, because we thought maybe it's because our psychotic group was too healthy. We're an outpatient unit here. We don't have the really, really acute patients normally. But in this case, we specially recruited patients that would classify as being acutely delusional, and we compared them to healthy controls, and we thought we're much more likely to find a difference now because of the strong link between negative affect or emotion and delusions. So that was one difference. And also in this experiment, we compared 3 strategies. We didn't just look at reappraisal compared to just view, but we also looked at the effectiveness of distraction and acceptance. And what we found, first of all, was that reappraisal and distraction were more effective than acceptance and than just view conditions. So again, the basic assumption that reappraisal works, and I think that's what James Cross also really emphasized in his talk, was confirmed. But again, we found no group differences in the effectiveness of using these strategies between the patients with acute delusions and the healthy controls. So they were equally effective at using reappraisal, they were equally effective in using distraction and acceptance. as the controls. And here in this study, we also compared sadness inductions with anxiety inductions, because we thought maybe we'd just find the pattern if we looked at anxiety and not at other negative emotions, but we had no interaction with type of emotion either. So we had no condition time group interaction, we had no condition time group emotion interaction. What we did have, actually in both studies, but here you can see it even more clearly, is a baseline group difference in negative emotion. So the patients with acute delusions start out from a much higher level of negative emotion than the healthy controls. So these were two studies with no group effect. And actually, if you look at all the other studies that have been conducted using experimental designs, they all haven't found a group effect in self-reported emotion regulation success in these experimental paradigms, except for one study by Westermann et al. Did. So as I mentioned before, the experimental findings can also be combined with fMRI to look at neural outcomes. And if we are going to look at neural outcomes, which we didn't, but other research groups have been doing, it's interesting to think about what we would actually be expecting. And one thing one would expect is that if emotion regulation strategies are not being used as effectively, then we'd see higher levels of amygdala activity after the use of strategies compared to healthy controls. And another thing that I find actually almost more interesting is that it's been looked at what happens actually in cognitive control regions during emotion regulation. So especially reappraisal is likely to draw upon regions that are responsible for semantic and self-reflective processes, for working memory, for selection and inhibition of appraisals, and for allocating resources during processes that require goal-oriented attention. So many of the important prefrontal regions. And there haven't been many studies using fMRI in psychosis, but there's a meta-analysis that you might know by Silverstand et al. That looked at findings from fMRI and EEG studies across different disorders. And they found that across different clinical populations, individuals consistently demonstrated a reduced recruitment of the ventrolateral prefrontal cortex and the dorsolateral prefrontal cortex during the downregulation of negative emotion. So thus showing a core deficit in the selection, manipulation, and inhibition especially during reappraisal. And only in mood disorders did they find effects on the amygdala responses. And here I have added the findings for schizophrenia. They were not actually reported in this way in the paper, but you can see here that the pattern is quite similar. And for anxiety disorders and schizophrenia, so there's no effect on the amygdala, and that actually corresponds quite well with the absence of an effect on the self-report. And but it indicates that there seem to be some difficulties going on nevertheless. And what the paper by Silverstand also did quite nicely was to demonstrate the difference in the findings using self-report measures and neural outcomes. So what you see here is that over all disorders using self-report measures, only 5 found a significant effect in the experimental designs. And whereas in EEG, it was 1 of 4 that found a significant effect. And in the fMRI, it was 27 of 31 that found a significant effect. But of course, this effect did not capture the outcome of emotion regulation, but captures the process of emotion regulation, at least when you're looking at the prefrontal regions. And we complemented this graphic again with the results from schizophrenia research. And the pattern here of the discrepancy between self-report and neural outcomes was even more pronounced. So that was the research using experimental paradigms, and I'd now like to move on to research using the experience sampling method to study emotion regulation strategy use and emotion regulation success in daily life. And the designs that have been used here are quite similar really to the experience sampling designs that have been used to capture psychotic symptoms and emotion in daily life, just that now additional items are added on, items that assess emotion regulation strategies, and they've mostly been taken from the validated questionnaires used to measure emotion regulation, but reduced to a couple of items for each strategy. So, for example, a participant would be asked, given the following item, I try to reappraise the situation in order to feel better, and then to rate this with a yes or a no, or on a rating scale, say from 0 to 4 or to 6, depending on the study. And several studies have used this approach. And again, I'm going to give you one example. This is a study by Lea Ludwig, who was a doctoral student in my lab. And she's the one who also did the meta-analysis, and this is her second piece of work. And in this study, she compared a clinical sample, the same clinical sample actually as we had in the experimental study that I talked about just now, patients with a psychotic disorder and acute delusions. And these patients were assessed at baseline using the Emotion Regulation Questionnaire by Gross and the Emotion Regulation Skills Questionnaire by Berking that assesses a whole another range of adaptive strategies and also emotional awareness, emotional tolerance, and so on. And then the participants were sent into an experience sampling period of 1 week where they were assessed for emotion regulation and emotions in daily life. And what she and we were interested in is to see whether which strategies the patients are using, whether there's a difference between the strategies that the patients with psychosis use and the healthy controls use. And even more interested we were in seeing whether the strategies work. So we did quite a complicated analysis where we looked at negative emotions at time 1 and used them as a predictor of change in emotions from time 1 to time 2. Or actually to say it's not time 1 and time 2, but it's time t. So any given time point, does the use of a strategy at any given time point predict a change in emotion from that time point to the next time point? And what we found, first of all, was we looked at the baseline strategies, and as expected, also based on the findings from the meta-analysis, we found that the psychosis group reported more use of suppression as a strategy and, compared to the controls. That was significant. They reported using less reappraisal, and they had a lower score in the Emotion Regulation Skills Questionnaire that assesses functional and helpful emotion regulation. So that was as expected. But then moving on to what they used in daily life, we came across quite an interesting pattern where the patients are actually showing overall, you can see the blue bars, are similar to higher frequency of strategy use. For example, they're using a lot more distraction, and they're using, which is maybe surprising, and they're using a lot more rumination, and they're using a lot more suppression, and they're even using more cognitive reappraisal in daily life. So this study does not indicate that patients aren't trying to make use of strategies. They are trying to make use of strategies. So this leads us to the question of how effective these strategies are in their daily life. And first of all, we also looked at, before coming to the really interesting question of effectiveness, we also looked at whether self-reported strategy use at baseline, so in the questionnaires, would predict negative emotions or negative affect, NR, this stands here for negative affect, in daily life, and we found that this is the case. So patients and controls that reported to use more reappraisal in the questionnaire, they were experiencing more negative affect in daily life, and those reporting to use more adaptive strategies were experiencing, adaptive strategies and reappraisal were both associated with less negative affect in daily life. And now to move on to the question of effectiveness or efficacy in daily life. We found somewhat puzzling pattern, actually, which raises some questions. We did find that reappraisal was associated with a decrease in negative emotion. So people using reappraisal at one time point, at a given time point, were less angry, worried, sad, and ashamed at the next time point. So that's good, and it means that we're sort of on the right track. But we also found that being aware of emotions was predictive of less negative emotion at the next time point, although you can argue a little bit about whether awareness is actually a strategy or whether it's a precondition to using emotion regulation skills, but I'm not going to delve into that now. But now the puzzling findings, we found that suppression and rumination were actually effective in reducing negative emotions at the next time point as well. And all of these associations, except for suppression, were the same for both groups. So there was little moderation by group. The only moderation by group that we found was that suppression was only working for the patients and not for the controls. So in these findings, there is really no evidence that patients are using strategies less effectively. They're using a lot of strategies, and the strategies are bringing down their negative emotions to the same extent as they are in the controls. And in fact, what's interesting here is that some of the putatively maladaptive strategies, such as suppression and rumination, seem to be having a short-term positive effect. We didn't look at long-term effects here, so that, of course, would be interesting. But again, there's one problem in this design, and it's the same problem that we faced in the experimental design, and that's that the intensity of negative emotion that patients are reporting in daily life is higher, almost 2 points higher. I think it was 1.5, actually, 1.5 points higher on average than the intensity of negative emotion in the control group. So what's actually happening here is that although patients are using strategies and bringing down their emotions in the desired direction, the negative emotions don't come down to the same level as they are for the controls. So all of this is happening on a higher level, which sort of raises the question of whether you can really say that it's equally effective, or would you say to be equally effective, it's got to come down to the same level as for the healthy controls. So it's sort of a little bit of a definition as what we would define as success in the end. And that's maybe a question that we can come back to at the end, or that you might encounter in your research as well. And finally, to close the chapter on experience sampling studies and psychosis, there have been some studies, one of ours as well, looking at whether the use of certain emotion regulation strategies in daily life moderate the link between emotional experiences in daily life and psychotic symptoms. So whether that feeds in then to the effective pathway to psychosis, and we found that it did. We found that participants that reported higher awareness of symptoms, for these participants, negative emotions were less likely to translate into psychotic symptoms, and participants that were using a lot of rumination we found that it was more likely that negative feelings would translate into psychotic symptoms. So this is actually the same data set as in the study I reported on just now. And this is quite interesting because we can see that although rumination was effective in bringing negative emotions down on a short-term basis, it came at a price. And the price was higher levels of psychotic symptoms at the next time point. So I'd like to summarize now. To summarize what I was talking about at the beginning, we can say quite clearly that in psychosis, and that's maybe not specific to psychosis, but a really clear pattern here, that we find that negative affect predicts psychotic symptoms and mediates between social stress and psychotic symptoms, and that emotion regulation difficulties are clearly present in self-assessment and in terms of autonomic self-regulation, in terms of heart rate variability. And there was clear indication that emotion regulation problems moderate the link between negative affect and psychotic symptoms, both in the questionnaire designs and also in the experience sampling studies. Overall, there is little indication of specificity of the problems to psychosis. I didn't really present that much research where we had other clinical control groups to keep it a bit more focused, but we have been comparing our psychosis groups to groups with anxiety disorders and depression in some of the studies, and there are there's no indication that people with psychosis have stronger problems in emotion regulation. In fact, the problems are even more pronounced in the samples with affective disorders, which speaks for and psychosis and anxiety disorders had somewhat similar levels, which sort of speaks for a transdiagnostic problem. And now to come to the paradox, and I'm curious whether this is what you perceived as paradoxical as well. I thought it's paradox that the experimental studies, at least in the self-reported outcomes, indicate that the patients with psychosis and other disorders are equally successful in downregulating negative affect when they are using instructed strategies, although they report all these difficulties in the questionnaires. And equally paradox, I thought it was to find that patients with psychosis are using an equal or an even higher number of functional strategies in daily life, although in the questionnaires they're reporting to be using strategies less or less successfully. So that leads me to my last slide. That's where to go from here. I think that there is a validity problem with the questionnaire measures, and that the questionnaire measures need to distinguish better between frequency and success of strategies, and need to be clearer what they're actually referring to. I think some of the questionnaires show a too strong overlap of sort of general coping and coping with situations and not really dealing with emotions. And then I think that we need to find better solutions to the baseline different problems, especially in the experience sampling designs, but also in the experimental and questionnaire studies. Do we control for baseline emotions, or does that take too much out? What would that mean? Then in experimental research, there's the instruction problem. So how much effect is that having? It's a difference, of course, using a strategy after being instructed than using it without an instruction in your daily life. That's why I would have expected that the problems show up more clearly in daily life, but yeah, as I said, that they didn't. And I also think it's important, perhaps in the experience sampling research, to distinguish better between the short and long-term effects. So that's certainly something that we will be looking at more in future. And to broaden the perspective on emotion regulation in psychosis to include some of the things that have been discussed in the field of emotion regulation in general, namely to look more also at positive emotions and how they are increased, and what a difference is there between clinical samples and non-clinical groups, how emotions are praised, and at interpersonal emotion regulation. strategies. So social sharing, so yeah, in the area of psychosis especially, that would be interesting. Okay, and with that, I'm at the end, and I'd like to thank you for your attention. And I'd also like to thank my team in Hamburg, of whom many have been conducting these studies and doing the everyday nitty-gritty work of this research, whereas I have the honor to be presenting it at the end. And I'm curious to hear your questions.
Okay, thank you very much, Dr. Lincoln, for your nice talk. Yes, we have some questions. I'll talk in Spanish, okay? But la primera dice, desde sus investigaciones, ¿qué enfoques de psicoterapia resultan más eficaces para pacientes con psicosis?
Okay, so the question, which interventions are more efficient for patients with psychosis is that's a very general question outside the area of emotion regulation, and it's very difficult to answer because if you're thinking of differences between CBT and psychodynamic approaches and systemic approaches, then there haven't really been very many studies on psychodynamic approaches to really answer the question of how effective they are. There's been a lot of research on CBT, and that's come up with reliable effectiveness for positive symptoms of psychosis, with effect sizes though in the small to moderate range, which is why there's still a lot of ongoing research trying to improve these effects. And for systemic therapy, there have been some studies also showing it to be effective.
Okay.
Does that help?
I think so. The next one dice, el aumento en la vivencia de intensidad emocional, ¿podría sobreestimar algunos resultados sobre estrategias de regulación emocional?
Yes, that's so. The question is the overall increased emotional intensity. Could it lead to overestimating results? Yeah, it's certainly got to be taken into account in the interpretation, whether it leads to an overestimation or an underestimation. I mean, it certainly explains why patients are using more strategies, because obviously you would only be using a strategy if you've got more feelings that you don't want to have, and as they are reporting more negatively valenced emotions, they're probably more motivated to be doing something about them and using more strategies. So actually that's not surprising. The question is how to solve that problem, really, because I haven't really come up with a design yet where we can get the patients and the controls down to the same level of emotional experience and then start out from there.
Next one is in English, so it says, how difficult is for a psychotic patient to learn and put into practice the emotion regulation?
Yeah, that's also a good question. We've been conducting a study where we focused more on emotion regulation, so not classic CBT, but using sort of third wave approaches and to support sort of emotion awareness and acceptance strategies. And yeah, we're still in the process of analyzing the results, but it looks as if we are going to find an effect on emotion regulation, so that we were successful in actually increasing the emotion regulation skills in this group.
Okay. I think because of the time, the last question is...
Sorry, I took too much time.
En términos prácticos, ¿qué es lo que hacen realmente los pacientes al reevaluar o reconsiderar los síntomas psicóticos?
Yes, that's a very, very good question that we've also been asking ourselves. So you could even ask yourself with patients with delusional symptoms whether they're using reappraisal in the way that that is adaptive, or whether they're not using, whether they may be using reappraisal in terms of a delusional explanation. So yes, I think it would be interesting to do research and really look at what patients what is the content of reappraisals, especially of reappraisals in daily life, to be able to answer this question. Because of course you could have the theory that delusional explanations are a kind of emotion regulation. And in fact, we did even conduct a study once where we showed that presenting people with a sort of paranoid explanation, that actually leads to a decrease in negative emotions on a very, very short term basis. So yeah, that's an interesting question, and that could also be an explanation why maybe in the lab things look a little bit different, because the type of reappraisal is pretty straightforward and instructed in the lab.
Okay, we are on time. Thank you very much, Dr. Lincoln, for accepting our invitation and for your nice presentation. So I hope we keep in touch. I'll write for asking some questions. I couldn't do it because of the time here. Yeah?
Yes, I'm sorry that I took a little bit longer. I wasn't.
No.
But I'm happy to take further questions via email. So.
Yep. Okay.
Okay. Thank you.
Bye.
Goodbye.
Bye.